That was awesome. Thank you so much, Barry School. Awesome. Thank you. And welcome back, everyone, from lunch and our break. I had an opportunity to peek in at the breakout sessions, and I saw some really great dialogue happening. I don't know, I hope we're all learning something today. I know I've already learned a lot, and every year we do this, there's something more to learn. And so, as we near the end of our conference, I want people to be mindful of how we combat HIV stigma. And so here to help us discuss best practices in addressing and eradicating stigma, please welcome to the stage, if I can turn the page, Dr. Ann Stangl. She is a behavior scientist and a stigma specialist at the International Center for Research on Women, among many other things. Again, bios are in our program book. And Dr. Snell, who's the Dean of Social Work at Howard University. He is also, I believe, associate professor and or a professor. You know, all those lines you guys have here. Professor here at Howard University. I'd like to welcome them to the stage to start our second plenary, to wrap up, you know, all the great things that we're learning here and discussing. Please come to the stage. Yay.
Well, good afternoon, everybody. Kudos to everyone for making it to the final plenary. I know it's always tough, so we're really pleased that you decided to stay and join us for this last plenary session. I think this is a really excellent way to wrap up the conference because we really want to leave on a note of action. What can we all do to actually start reducing stigma in our own lives, in our own communities, and around the world? And so we're going to be hearing from a number of distinguished speakers today who are going to tell you a little bit about the stigma reduction work that they've been doing globally. So with that, maybe we should bring up the speakers. And we'll introduce you all right before your presentations. And I'd also just like to take this opportunity, I've been asked to say on behalf of Howard University and the conference organizing committee members that they would like to recognize the governments of Peru and Uganda for the extensive efforts that their governments have been doing over the last decade to reduce HIV stigma and discrimination. We wanted to commend these countries for their efforts and make sure that we mentioned that today. There are representatives from both the Consulate of Peru and the Embassy of Uganda here with us today, and we're going to be learning a little bit about some of the stigma reduction interventions that are actually happening in both of those countries. So we're really excited to hear from those panelists today as well. So on that note, I'm going to turn over to Dean Snell, who's going to introduce the gentleman from Peru.
Good afternoon. Buenas tardes. It is my pleasure to introduce the Consul General of Peru, who will introduce Ms. Ximena Salazar. On February 15, 2010, the President of Peru designated as Consul General of Peru Mr. Cesar Jordan in Washington, D.C., Minister in the Peruvian Diplomatic Service. He has an extensive CV, so I'll just highlight in the interest of time some of his important contributions. He's been a career diplomat for 29 years and served in Cuba, the Vatican, Ecuador, Japan, and Israel. He's a well-educated man. He has 5 degrees, I think I counted, or 4. He has a law degree from Catholic University in Peru. He has a diploma in international relations from the Diplomatic Academy of Peru. He has 2 master's degrees, one from the Diplomatic Academy of Peru and the Ministry of Defense in Peru. His area of interests focused around media and political affairs and international cooperation for development. So without much further ado, we welcome the Consul General to the podium to introduce our speaker, Ms. Ximena Salazar. Thank you.
Thank you all. Buenas tardes. Ladies and gentlemen, Dr. Snell, thank you very much. It is indeed a great honor to participate in this special occasion where awareness and non-prejudice are the focus point to break the silence conspiracy, the greatest obstacle to fight AIDS worldwide. As Consul of Peru, my honor doubles when the occasion comes also to celebrate my country's achievements in this purpose and to impersonate these achievements today in Dr. Ximena Salazar, Executive Coordinator in the, I'm going to say this in Spanish because it's too long, Instituto de Estudios en Salud, Sexualidad y Desarrollo Humano of the Cayetano Heredia University in Peru. From now on, the Instituto. I just wrote a little joke, but it's not going to work anymore. But, however, I wanted to make an announcement regarding mental health. Mental health is also a public health issue, and thus, in the interest of clarity and mental sanity of everybody's here, I was going to continue the rest of my introductory remarks in Spanish. Not anymore. Tomorrow, so I'm going to translate from now on. Tomorrow we are going to commemorate once more the World Day of AIDS, which motto this year is Reach Zero. Zero new infections HIV-related, 0 deaths related with AIDS, and 0 stigma. So we are in focus now. Even though in 2011, 2.5 million adults were infected with HIV and 1.7 million persons died for causes related to HIV, 25 countries have already achieved reduction, actual reduction of HIV-related infections in a rate of 50%. That means globally, 700,000 less new infections than 10 years ago, and 600,000 less deaths than 2005. That is very important. So 600,000 persons are alive now because of awareness. These efforts motivate to keep working, and Latin America is now a point of interest because of its high coverture, 68% of treatment among the regions of low and middle income. Nevertheless, some groups are still unattended, like health workers, sexual workers, gay men, trans persons, and young people. This is directly related with the stigma and with discrimination, and shows us the necessity to strengthen capacities to provide services for these groups, marginalized and vulnerable, according also, of course, with principles of public health and especially human rights. I have the pleasure, I'm very happy to outline that according data of our Ministry of Health, supported by IPAJO, from 2004, when treatment against AIDS initiated in Peru, mortality for these epidemics dropped in 55%, and the number of cases reported each year in the country is stationary now, and with a tendency to drop. Not only this, Peru, together today with Uganda, is one of the only 2 countries in the world that have actually achieved to drop also levels of stigma in health. Our government recognizes these fruits are due to a multidisciplinary and especially multi-sectorial work where state, academy, and of course civil society are deeply committed. Institutions, as the one represented today by Dr. Salazar, are part of this effort. The Instituto is a multidisciplinary entity that tries to generate knowledge in health, sexuality, and human rights, directed to achieve change in public policy and social policies in our country in the frame of the respect to diversity, gender, and social justice, fighting against exclusion and discrimination in the fields of health, sexuality, and sexual rights. Dr. Salazar, here today with us, is an anthropologist for the Catholic University of Peru, with specialization and very important universities in Peru, Argentina, and Germany. She is a researcher in institutions of Peru and the United States with an experience especially in the area of reproductive health and project evaluation in urban and rural areas. Her career as an anthropologist precisely deepens in the attitudes of men before the world that surrounds us. And the stigma is precisely that. It's an attitude against the world epidemic of AIDS. It's an attitude that we have to study, we have to manage, and we have to change. This deep commitment of Dr. Salazar with the matter is demonstrated in her participation in research and her publications on matters as relationship between consumption of drugs and alcohol and HIV infection, the perception of poor population about social programs in Peru, the socio-cultural context in the risk perception to get HIV infection, and the special vulnerability of the poor population and the violence against sexual workers and persons in risk. We thank Dr. Salazar for her personal and institutional contribution in this Peruvian achievement, and please join me to welcome and honor Dr. Ximena Salazar.
So, my presentation is Fighting HIV Stigma and Discrimination in Peru. Okay, the HIV epidemic in Peru is more than 25 years old. According to data reported by the National Department of Epidemiology, the main route of transmission remains sexual with 97%. The HIV epidemic in Peru, according to UNAIDS, is a concentrated epidemic because of the HIV prevalence among men who have sex with men, which is above 5%, while the prevalence among pregnant women, which is used to characterize the epidemic in the general population, remains below 1%. Here we must emphasize that the term MSM has been used as a concept that encompasses gay, bisexual, and transgender women. We consider transgender women as one of the most at-risk populations to HIV/AIDS, and while they have assumed a female identity, they need to be regarded as a specific population rather than subsuming it in the MSM category. This population, as you can see, has a prevalence of HIV infection of 29% in Peru. This picture shows more specifically the dynamics of the epidemic in Peru. I will not explain but it's the people people as risk are here. Those are breech populations who are clients of sex workers and bisexual men and all. And here are the general population. And the HIV infections go from here to here. The characteristic of stigma in Peru. The evaluations made by the Global Fund program that operated in the country from 2006 to 2012 allow us to track the characteristic of stigma and discrimination in Peru during those years. These evaluations handled the following indicators. The first indicator is the percentage of the population of the intervened regions having an attitude of acceptance to people living with HIV and other vulnerable populations. This indicator measured using a probabilistic survey in households allows us to observe that in 2006 only 50% in 8 regions of the country had an attitude of acceptance to people living with HIV and other vulnerable population. In 2012, this percentage of people having an attitude of acceptance to those populations was increased to 76%. In 2006, the following features were found in the qualitative evaluation. Big misinformation about HIV transmission and its characteristics, serious problems of stigma towards MSM, sex workers, and transgender women compared with women and children living with HIV. The changes that were observed in 2012 from a qualitative point of view were a greater acceptance toward people living with HIV in Lima and Callao. Lima is the capital of the country, but less in other regions, and an increased awareness and information on HIV. The second indicator is the percentage of school teachers having an attitude of acceptance toward children living with HIV. This indicator was measured through a survey in schools in 8 regions of the country and allows us to observe that in 2006, 64% of school teachers had an attitude of acceptance toward children living with HIV, while in 2012 this indicator increased to 85%. According to the qualitative evaluation in 2006, we found an attitude against the possibility of having children living with HIV in the schools and issues of stigma in parents. The changes that were observed in 2012 were an organization of meetings against stigma and discrimination in schools, school teachers facing parents who express stigma toward children living with HIV, and a mainstreaming of human rights in schools. The third indicator was percentage of healthcare providers having a positive attitude towards people living with HIV and other vulnerable populations. This indicator was measured through a healthcare provider survey in 8 regions of the country and has revealed that in 2006, 81% of healthcare providers had an attitude of acceptance to people living with HIV, while in 2012, this has increased to 91%. Related to healthcare providers, it was observed, according to the qualitative study, that healthcare providers working in HIV clinics had a position of defending the rights of people living with HIV. Although we observed important differences in their quality of care according to the populations, mother and infants versus gay and bisexual men and transgender women. The staff working in other programs stigmatize people living with HIV and do not respect confidentiality and take inadequate attitudes to these persons. During 2012, we saw that the situation has changed gradually, although in some places they still have attitudes of stigma and discrimination. They also still show many prejudices and stigma towards gay men and especially transgender women. The conceptual framework of HIV stigma that we manage is, in Peru, HIV is associated with non-normative sexualities. We identify two components of stigma, one linked to the disease and other associated to the pre-existing stigma from sexual behavior, a determinant of AIDS-related stigma, corresponding to what is called layered stigma. The concept of stigma applies when 5 elements converge: labeling, stereotyping, separation, status loss, and discrimination. None of other social aspects is as powerful as sex. This symbolic charge is due to the association between HIV and sexual behavior that results in a spoiled identity, based on the representation of stigma as a deviation from normal and acceptable social attributes. Additionally, personal factors such as prejudices, values, and beliefs contribute to the rejection or, for instance, to the substandard care of people living with HIV, members of vulnerable populations. Stigma has a negative impact on social interaction, employment opportunities, emotional well-being, and self-perception. HIV stigma is not a static concept, but a process associated with other stigmas, such as stigmas surrounding non-heterosexual orientation or being a sex worker. I want to talk about interventions against stigma and discrimination now. Interventions have to be designed according to the needs of local and national contexts. Interventions combine biomedical, behavioral, and structural elements to reduce immediate risks and vulnerabilities involving affected communities, promoting human rights and gender equality, and work synergistically at different levels: individual, family, and society. I want to talk about structural intervention. Specifically, structural interventions seek to change social, political, and environmental factors that affect individual and community risk, and prevent social exclusion, restrict access to appropriate services, and increase vulnerability. Structural interventions include also access to health services and prevention without stigma and discrimination, raising awareness among justice and police operators, improvement of legislation and education systems, and media sensitization. Structural interventions have a multi-sectoral approach depending on political decisions and seek to change the conditions surrounding individuals that affect their decisions. These interventions allow enabling environments to reduce stigma and discrimination. Now I want to show some examples that interventions that we have done in Peru in my institute. The first example is Vivo con VIH, which is I live with HIV, experience art against stigma and discrimination in health services. Healthcare providers in hospitals must wear a t-shirt printed with the word HIV, as if they were wearing the stigma and care for their patients. This symbol, VIH, the Spanish acronym for HIV, is transformed by artists to vida, life. Stigma is then transformed into hope. The second example is the intervention on human rights, sex work, HIV and AIDS in Peru. This intervention promotes a direct participation of sex workers, biological women and transgender women in the intervention design, implementation and decision making. The intervention was a multiple level intervention, structural, community and individual level, with constant advocacy efforts for sex workers and human rights at national, regional and local level. The main activities of this intervention was sex workers' community strengthening, training of community organizations nationwide, and leadership training, and sensitization to authorities, municipalities, police, judges, and healthcare providers about sex work at regional level, and also propose for amendments on Peruvian sex work law. The third intervention I want to show is the LGBT communities, human rights, and HIV/AIDS. This intervention seeks to highlight the respect for human rights in order to reduce vulnerabilities generated by stigma and discrimination against LGBT communities, including people living with HIV/AIDS, in 3 cities of the Peruvian coast, Lima, Callao, and Ica. The main activities were LGBT and people living with HIV organizations, sensitize judges, police and healthcare providers against stigma and discrimination. And also we built a human rights observatory managed and administrated by LGBT and people living with HIV communities. Now I want to talk about some conclusions and lessons learned. Stigma is rooted in the life of those who stigmatize and who are stigmatized. When someone is stigmatized and discriminated, he or she will experience many restrictions in his or her social life. That causes the inability to change things. The stigmatized person internalizes and accepts this rejection. With respect to health care services, stigma constitutes a major obstacle to the quality of care and support that people living with HIV require. Sexual orientation, gender identity, and HIV/AIDS related stigma leads to discrimination, which is crystallized in abuse, neglect, and even violence. Interventions such as the ones we have presented are needed, as well as biomedical and behavioral intervention. And those efforts should be coordinated, evaluated, and extended. Thank you.
So thank you, Dr. Salazar, for that excellent presentation. In the interest of time, we're going to hold all the questions to the end and ask that the speakers try and keep their presentations as succinct as possible, since we're running a little behind. So next, I'd like to introduce Dr. Pauline Muchina from UNAIDS. She's going to be telling us a little bit about UNAIDS' approach to stigma reduction and some of the work that they're supporting. And she's also going to share some of her personal experiences. Pauline?